go on for the first question for this day. Dr. Mala Srivastava, it is addressed to you by Dr. Rupali Sharma. She wants to know what is the role of vaccination in prevention of carcinoma cervix and which vaccines are available in India and who should take it and the schedule. If you could just tell us just in short, since you are a clinician.
Thanks, Dr. Preeti. Very relevant question. Vaccination is the primary prevention, as Madam already highlighted in her keynote address, that vaccination is primary prevention for CS cervix. Ideally, the girls should be vaccinated between the age of 9 to 14 years before they start the sexual debut. That's the best time for the girls to have the vaccination. It gives them good immunity and it's a good prevention for CS cervix. Now the vaccination, we have bivalent, quadrivalent and nonavalent. Nonavalent is coming into India, but bivalent and quadrivalent are readily available. Bivalent is against HPV 16 and 18. And as we all know, most of the CS cervix precancerous lesion as well as cancer is 80% caused or 70 to 80% caused by 16 and 18 varieties of HPV virus. And quadrivalent has 4 of them, 9, 14, 16, 18. So 16, 18 is for precancerous and cancerous lesion of the cervix, but the other 2 is for the warts. So nonavalent is also coming up. It has not yet reached the Indian market. Maybe some places you are getting nonavalent vaccine. This has, in addition to 16 and 18, other high-risk varieties of HPV viruses. It is against 33, 35, 45, 55, and 46. So we have 3 varieties. 2 is readily available in India. The schedule for bivalent is 0, 1, and 6 months. For quadrivalent, it is 0, 2, and 6 months. For nonavalent, also it is 0, 2, and 6 months. This is the schedule for the vaccination. Vaccination prevents almost 80 to 90% of cases of CS cervix because it is against 16 and 18. But there are other less prevalent cases of high-risk HPV viruses which can produce CS cervix. So it is not protecting against 100% cases of CS cervix. So you have to impress that even after taking vaccination, these girls have to be screened periodically. Screening has to be there, even if the girls have had their vaccination. So that is an important message to be given to our girls.
Yes, that is very important. Like a lot of people have this question that I am vaccinated. Do I need to undergo routine screening? Yes, they still need
screening.
To undergo.
Still has to be done.
Yes, yes.
Because there are 14 high-risk type of HPV viruses which can cause CS cervix. Of course, 80% is caused by 16, 18, and we have vaccine against them. But there are other varieties also which can cause CS cervix. So screening will still remain.
Dr. Mala, there's another question. I think you should take this question. This question is from Dr. Divya. She has asked, ma'am, what is the management of patients who are reported as shift in vaginal flora suggestive of bacterial vaginosis, as we give in our pap smears? Do we put them on antibiotics straight away or are they kept on follow-up?
See, basically, if they are really symptomatic, they need local antibiotic therapy. Depending on the patient's complaint, patient's symptoms, patient's sign, you have to treat them because we cannot just wait for the local immunity to take over. They may need treatment depending on the situation.
Okay, thank you.
There's a question for Dr. Nuzhat Husain from Dr. Rupali Sharma. Dr. Nuzhat, how HPV testing can be applied in Indian population? Actually, this question already Dr. Kusum Verma had told in her talk. But if you could just elaborate on this, like in Indian population.
The basic drawback with applying HPV testing in the Indian population is the cost. So one would have to actually negotiate to get a good cost for the HPV screening. maybe, and as Dr. Kusum said, an innovative test which is manufactured in India, or even if tests which are coming from outside, if we can validate them at a low cost in our settings, that would be good. The second is we need to also establish a network of collection, whatever methodology of screening, and a network of follow-up, because there is a very important part of the testing followed by the handshake with the treatment. So that network, I believe, should very strongly be established from major tertiary referral centers, which should do the molecular testing, to the district hospitals, to the CHCs and the PHCs, to the ANMs, and we should encourage home self collections as well. That would kind of increase the input of the samples that are coming. And when you have those numbers, I think you can generate a good cost test as well. So we need to shift to HPV testing. I think the Via Villi program has had its drawbacks and problems so far because of the non-compliance, also the inefficiency with which the screening is being done by non-medical people. We don't have the numbers of gynecologists to actually do the screening themselves. And therefore, we really need to shift to the screening with the HPV. Definitely, I believe that.
Okay. Thank you. Dr. Pooja, there's a question for you.
Preeti,
Yes.
there's one thing I would like regarding the
Yes,
question
ma'am,
of
sure.
vaccination. In Western countries, they are even talking of vaccination for boys because they say ultimately HPV infection is brought through the male partner. So why only vaccinate the girls, vaccinate the boys? And in some countries, they have also started vaccinating boys in the adolescent age period. So this is, just to supplement Mala's answer.
Apart from the fact that HPV is also causing cancers at other sites other than the uterine cervix. So, it's the HPV associated oropharyngeal cancers and then anal cancers and others. So that's why also both genders to be vaccinated.
Yes, absolutely. Dr. Pooja, there's a question for you from Dr. Priya Savla. When can we say the pap smear is satisfactory? So,
yes, this is a question we ask students in the Viva. Yes. When will you say that pap smear is satisfactory? So, of course, the criteria are different for the conventional and for the liquid-based cytology. So, for conventional, we know that ideally there should be at least 8,000 to 12,000 cells in the smear. And there are image comparisons which you can do to ascertain how many cells are there roughly. So you can do that image comparison. Those images are available. Whereas for liquid-based cytology, the recommended is 5,000 cells in that sample. So there are various ways in which they have suggested. You obviously cannot sit and count all 5,000 cells. So you see your field diameter of your microscope lens and the preparation that you're using. What is the diameter of the liquid-based cytology preparation you are using? If it is a short pat method, which has a smaller diameter as compared to thin prep, it is about 13 millimeters. So there, if your microscope lens area fits with what is, there are tables which are given, recommended by Bethesda. And if you have, say, roughly 7 to 8 cells per hyper field, after counting random 10 fields, then it is considered as adequate. Whereas for thin prep, it is about 3 cells per hyper field because the diameter is bigger. So you need to assess as per your microscope lens diameter and the preparation that you are using, whether you are getting 5,000 cells.
Thank you, Dr. Pooja.
Dr. Nuzhat, there was one question. I don't know who asked it, but I noticed in the chat box about how many high-risk HPV types are really there and how many are we really targeting in all these tests?
I did post an answer to that from my presentation, that basically there's like a group of 13 to 14 which are high-risk HPVs, which are probably associated with malignancy. And then we have another cluster of about 8 to 10 which are likely or possibly associated with HPV. So this is like the larger cluster that we have to look at when we are looking at the high risk. Per se, the human papilloma virus has about 127 different subtypes.